Welcome back. We're here for lecture 20 where we're going to be talking about rheumatoid arthritis. First of all, just to put rheumatoid arthritis, or RA, in perspective, it is a disease that is an inflammatory and systemic disease affecting the whole body, but we're going to be looking primarily at its effects in the upper limb. We'll have some tangents to talking about some other findings, but again, our primary focus will be its manifestations within the upper limb. It's more common in females at a ratio of about 3 to 5 women to 1 man who's diagnosed. And the incidence or the occurrence of rheumatoid arthritis does increase with age, although most people are diagnosed in their 40s to 50s. Overall, about 0.5 to 1% of adults in the developed world do have rheumatoid arthritis, so it is a relatively common disease. Let's take a look at the disease. So rheumatoid arthritis, we're going to be looking at a systemic disease mainly affecting synovial joints. There is chronic destruction of this joint symmetrically, and if you remember back to lecture 3, we talked a little bit about the structures of the synovial joint. In particular, the main problem here that occurs is you see this inflamed synovium here, which begins to hypertrophy. Hypertrophy essentially means that the cells within that synovium start to grow in size. They can also grow in number, but primarily here we have a growth in size. And at that time, it forms what's called a pannus. That hypertrophied synovium starts to grow into the joint itself. Remember, the synovium itself had the function of producing synovial fluid, that egg white textured fluid that helps to lubricate and provide some shock absorbance within the synovial joint. In so growing, this pannus will start to cause these erosions of the bone, the tendons, and the cartilage that make up the synovial joint. And with that destruction comes pain, comes deformity, and ultimately causes significant difficulty with quality of life, significant difficulty with using those joints. So some of the clinical features here, it most commonly affects the MCP and PIP joints, or metacarpophalangeal and proximal interphalangeal joints. Notable by its absence here is there is no effect on the distal interphalangeal joints, the ones furthest out within the hand. But there also can be effects on other joints as well. The wrists, the ankles, the knees, shoulders, hips, and elbows, as you can see here, can also be affected. Rheumatoid arthritis with the damage to the joints, particularly at the metacarpophalangeal joints, can cause what's referred to as this ulnar deviation of the fingers. You see the fingers themselves are deviated essentially towards the ulnar or medial side of the hand. The reason for this, again, is that destruction of the joints. It causes some instability to the joints, and just based on the anatomy within those joints themselves, it does cause some deviation to one side or the other. It is possible to see radial deviation, but ulnar deviation is a little more closely associated with rheumatoid arthritis. It's considered a bit of a buzzword for the diagnosis of rheumatoid arthritis. Taking a look at some of the deformities that can occur in rheumatoid arthritis, the big two that are often referred to are these swan neck and boutonniere deformities. A swan neck deformity, as you see here, is essentially hyperextension of the proximal interphalangeal joint with a flexion of the distal interphalangeal joint. And the cause for this primarily is stretching of what's referred to as the volar plate. Volar and palmar are synonymous with each other. So this essentially is one of the structures within the palmar side of the hand, in particular at that proximal interphalangeal joint, that with the inflammation can have some stretching and again cause that hyperextension at that joint. Because there's stretching of some of the additional tendons within the hand, that causes the flexion deformity at the distal interphalangeal joint as well. A boutonniere deformity, on the other hand, which you can see illustrated well in this picture above, as well as the one below, is more of a flexion at the proximal interphalangeal joint and a hyperextension at the distal interphalangeal joint, essentially the reverse of the swan neck deformity. Boutonniere means buttonhole, and it's referring to essentially the development of this deformity and what's occurring. Essentially, the distal portion of the proximal phalanx, or proximal bone within the finger, begins to slip through the two slips of tendon that are on both sides of it, essentially sliding through like a button through a hole, and it's able to deviate itself to the posterior side of those two slips, causing again that flexion deformity at the proximal interphalangeal joint and a hyperextension deformity at the distal interphalangeal joint. Rheumatoid arthritis is also associated with rheumatoid nodules, which we're not going to expect you to be able to read microscope slides, but certainly even so, there are some features that you can see here that should make a bit of sense. Remember that all cells have nuclei, and so if we don't see many nuclei on a slide, that's telling us that either there are no cells there or perhaps dead cells are there. In particular, in a rheumatoid nodule, you see this large portion in the middle here, and this is what's referred to sometimes as fibrinoid necrosis. Fibrinoid necrosis is essentially referring to a proteinaceous material that's collecting within this nodule. Fibrin is a protein that exists in the blood. Fibrinoid means looks similar to or acts similar to that fibrin. So we essentially have a bunch of protein depositing in the middle here, and it's fibrinoid necrosis, necrosis referring to essentially death of cells and essentially their destruction in that process. Around that, we have what's referred to as palisading, macrophages, and fibroblasts. Palisading as a term means essentially that it's forming a fence-like structure around the rest of the nodule. And the two cells, again, that are within that are cells called macrophages. Macrophages are one of those stereotypical immune cells where their main function is to gobble up the material that's there, perhaps bacteria or dead cells, and be able to start digesting them. They're the one that we all learn about in our high school biology class where they like to gobble up a bacteria and digest it to help prevent infection. So we'll have those macrophages as well as fibroblasts. Fibroblasts help to produce a fibrous tissue. They're also what produces scar tissue. So they're essentially forming this connective tissue around the nodule. Further out than that, we see another group of cells, and these cells are primarily what are called T cells. T cells being another important immune cell. These are ones that in particular interact with cells that may be infected by viruses, or they also impact B cells. B cells we'll look at a little bit later because they produce antibodies, which are also a feature in rheumatoid arthritis. Also, we see in this portion plasma cells. Plasma cells are basically matured B cells that are starting to produce what's called antibody, and we'll be looking at the structure of antibody on the next slide. So rheumatoid nodules, again, we have this necrosis in the middle, surrounded by some cells trying to block it off, essentially, creating some scar tissue there and gobbling up the dead material. And further out, we have some additional immune cells that are promoting signals, producing antibodies, which we believe is involved in the pathogenesis or cause of rheumatoid arthritis. So taking a look at some of the systemic symptoms, somebody who has rheumatoid arthritis will often complain of feeling fatigued. They may have fever. They may have malaise. Malaise essentially being that feeling when you just feel wiped out and you just don't feel good. When you have those flu-like symptoms and just feel tired and sometimes irritable, that's malaise. They'll have often a lack of appetite, and they may have weight loss because of that lack of appetite, as well as due to the inflammation that's occurring in rheumatoid arthritis. They'll often have what's called anemia of chronic disease. Now, a lot of us know anemia that's caused by iron deficiency. Here, the cause is a little bit different. When inflammatory cells are present, they're often going to gobble up iron that's present in the body. They're actually doing this to prevent other cells, particularly bacteria, from getting that iron. Now, that's a good thing if somebody has an infection and they have an inflammation from an infection. It helps prevent that bacteria from being able to grow. But if somebody has inflammation on its own, these cells are starting to gobble up that iron for no real good reason. And if they're starting to gobble up that iron, it's not available to developing red blood cells, and therefore, again, can cause anemia. Again, it's because these cells don't have iron, but it's a little different than when someone doesn't have iron from a deficiency, perhaps because of dietary causes. Here it's because those immune cells are starting to gobble up the iron. People will often complain of morning stiffness as well, and one of the key things here is that it usually lasts for longer than an hour. We'll take a look at osteoarthritis in the next lecture. Osteoarthritis, usually there's some stiffness in the morning, but it's usually not that long of a duration. People may also be stiff after they've been sitting for a while, but in rheumatoid arthritis, it's usually something that occurs more in the morning than any other time of day, and it usually lasts for longer than an hour. So taking a look at the actual pathogenesis here, we mentioned antibodies before. Now, antibodies are used by immune cells to be able to target bacteria, group them together, and mark them essentially for destruction. There's 5 different types of antibodies. We're not going to go over them all in detail here, but suffice it to say 2 that we'll mention here are called IgG, or immunoglobulin G, and IgM, or immunoglobulin M. Both of these are again used by those B cells that we mentioned before to be able to target particular bacteria, mark them for destruction, group them together so that they can attack cells. One of the things that occurs in rheumatoid arthritis, or one of the things that we can test for at least, is the production of something called rheumatoid factor. Now, rheumatoid factor is an IgM molecule, a very large antibody that actually targets IgG, another one of these immunoglobulins. Essentially, you see these little areas on the end of the immunoglobulin. That's going to be where it can attach to and attack some other item. Again, normally a bacteria or maybe an infected cell. But here, that area, the active site essentially of the immunoglobulin, goes and starts attacking other immunoglobulins within the system. And when that happens, we end up with these very large aggregates of immunoglobulin protein. IgM attacks a number of IgGs. They form together into a large, what's called immune complex, and it becomes large enough that it starts to precipitate out within the joints. They start to deposit in those joints. Another thing that's often seen in testing is something called anti-CCP, CCP standing for cyclic citrullonated peptide. Cyclic citrullonated peptide is something that is often found in increased numbers in smokers, in particular in their lungs. So there is a bit of a connection between smoking and rheumatoid arthritis, although it is not obviously a complete causal relationship. But it's one of the things that often we'll test for that supports the diagnosis of rheumatoid arthritis. Finally, as we said, those antibodies, their job is to target protein or to target bacteria, and so they're going to be attracting inflammatory cells to the area. Those inflammatory cells come, they're looking for bacteria, they think they're around, and so they start to release chemicals that are meant to essentially destroy and kill that bacteria. Unfortunately, there is no bacteria there, and those chemicals start to destroy the joint contents themselves. They contribute to that formation of the pannus that we mentioned before from that synovial hypertrophy. So taking a look at the actual diagnosis, we mentioned some lab testing from before. Any diagnosis really needs a good history and physical exam to support it. The history, as we mentioned, often they'll describe that fever, malaise, fatigue. Often there will be pain in the hands, that morning stiffness lasting for more than an hour. And on physical exam, we may see again that ulnar deviation to the fingers caused primarily by the inflammation to the MCP joints. For lab testings, we mentioned again rheumatoid factor and anti-cyclic citrullonated peptide antibodies. And often on x-rays, we'll see some of the classic erosions. Remember, we will see effects in the metacarpophalangeal joints. You see a pretty significant amount of inflammation here, and again, some ulnar deviation to the finger. And we also certainly see some inflammation and erosions at those proximal interphalangeal joints, but again, notable by its absence, there is no effect here at that distal interphalangeal joint. That is not something that we see in rheumatoid arthritis. It may, by extension through the swan neck and boutonniere deformities, get a bit misshapen, but the inflammation itself is not occurring at that DIP joint. In terms of treatment for rheumatoid arthritis, the primary mainstay, at least in early stages of the disease, is based on pain relief. We're trying to reduce that inflammation using things like non-steroidal anti-inflammatory drugs like ibuprofen or aspirin. But certainly in later stages or more severe cases of the disease, we often have to use what are called DMARDs, or disease-modifying anti-rheumatic drugs. These are very strong medications. They are, as it says here, immunomodulators, which essentially means that they directly affect those white blood cells. They actually reduce the function of white blood cells. This includes medications like methotrexate, sulfasalazine. In the past, we actually used to use salts based on gold, what were called gold salts, and a number of biologic medications. You may have seen advertisements for these, and certainly we'll mention some of their brand names, although we're not supporting any particular drug in this class. But medications like infliximab, also called Remicade, rituximab, also called Rituxan, abatacept, also called Orencia, and etanercept, also called Enbrel. Those are all examples of some of these DMARDs, and we're not listing them for you to memorize them, but more just to be familiar with some of these names and to recognize the large number of medications that do exist that are these immunomodulators. These medications, by essentially turning off the function of the white blood cells, do have very significant effects in reducing the amount of inflammation. We can't really reduce destruction that's already been there, but we can prevent additional destruction. But sensibly, if it is affecting these white blood cells, a common side effect of many of these medications is infection, in particular tuberculosis infection, mainly because, again, if the white blood cells are not functioning well, they're not going to be able to go and attack infections as well. In the next lecture, we're going to turn our attention to osteoarthritis, a disease that has some similar findings, but certainly a lot of differences.